Madam, please.
Thank you, Dr. Tamina, and good morning, everybody. I'd like to thank Professor Fazlur Rahman, Professor Shajul Banerjee, Professor Nazrul Islam, Dr. Nilufar, Dr. Sabina, Tamina, and all the other members of the organizing committee for inviting me to such a prestigious conference of Bangladesh. I'm going to talk on the echocardiographic assessment of LV function, where I'll cover both systolic and diastolic. Out of all indications of echocardiography, perhaps assessment of LV systolic function is the commonest indication, because it is the easiest parameter of the LV function to understand. It takes a pivotal role in the evaluation of all the patients with known or suspected cardiac disease. It has consistently been shown to be a predictor of mortality and morbidity, especially after MI. And it has a vital role in deciding and guiding our line of management. Like if we get a patient of chronic, severe, asymptomatic aortic regurgitation, we always do repeatedly the echocardiography and to look at the ejection fraction, because class 1 indication of aortic valve replacement in this group of patient is the ejection fraction when it comes down below 50%. And not only that, the LV systolic function also guides the establishment of appropriate life-prolonging therapy in patients with low EF. In different studies, we have seen, and here the inclusion criteria again is LV ejection fraction. So we need to think twice before putting the figure for an ejection fraction. And we have to always calculate this ejection fraction by following the latest recommendation and guidelines of AEC to maintain a uniform standard worldwide. Now, when we measure the LV systolic function from the linear dimension, either with 2D or 2D guided M-mode echocardiography, it depends on how and where we measure. We should place the caliper perpendicular to the ventricular long axis at or immediately below the level of mitral valve leaflet tips. And we calculate the fractional shortening by the formula of percentage of LV end diastolic diameter minus end systolic diameter divided by end diastolic diameter. So the maximum dimension is the end diastolic diameter and minimum is the end systolic diameter. Now, since it is a one-point measurement, regional wall motion abnormality in the LAD territory is always a limitation of this method. And also conduction abnormality gives rise to the paradoxical movement of the septum where the measurement becomes difficult. Now, we can measure ejection fraction from the linear dimension by using the formula of ejection of percentage of end diastolic volume minus end systolic volume divided by end diastolic volume. Now, if we look carefully, see, we measure the dimension, not the volume. So what machine does, machine assumes a particular geometric shape of the LV and converts this diameter into volume by Tekol's formula. So, there will be always inaccuracies for geometric assumption. So as per the latest recommendation of the AEC, assessment of ejection fraction from M-mode or 2D guided M-mode is not recommended. The latest recommendation is the measurement of LV volume and ejection fraction from modified Simpson's method by manually tracing the LV endocardial border using two planes. So it is known as biplane disc summation method of 4-chamber, apical 4-chamber and apical 2-chamber, where we measure the end diastolic volume by tracing from one annulus to the another annulus, and we measure the length, in ends diastole of apical fourth chamber and end systole of fourth chamber, and repeat the same in two-chamber view, and we get the ejection fraction by biplane method. Now, these are the normal values as per the latest guidelines. Now, if we look at this summation method by 2D, we face various pitfalls, like foreshortening of the apical fourth chamber is a problem, which leads to reduction of the volume, and we face suboptimal endocardial definition, as you see here, and where again we have to do the manual tracing. It depends a lot on the user's experience, and though it is partly accurate, but since we use two cross-sectional views of LV, so there is every possibility of geometric assumption to some extent. All these factors lead to intra-observer variability, and we use myocardial contrast sometimes to enhance the endocardial margin, as you can see, and it improves the accuracy of volume and ejection fraction and reduces the inter-observer variability. So now the best method for assessment of volume and ejection fraction is three-dimensional echo. It is compatible with the cardiac MRI, and the advantage is that in the 3D echo is intrinsically volumetric. We do not have to rely on the geometric assumption, and that is why we can use the LV volume and EF measurement from 3D echo. Another underutilized method of assessment of LV systolic function is DPDT from mitral regurgitation. This is basically a rate of acceleration of mitral regurgitation jet from 1 meter per second to 3 meter per second. So it's in early systole when there is no significant change in the LA pressure. So it is not, aortic valve is not yet open, so it is not affected by afterload. Faster the LV pressure rise, better is its function. So to measure it, we should have a measurable mitral regurgitation. We do the CW Doppler at MR from apical fourth chamber view and measure the time interval in millisecond between 1 to 3 meter per second. Now, and we utilize, if the machine has got the software, machine will give the value, or if you don't have, then utilizing this time in millisecond, we can divide 32,000 because the difference of pressure gradient is 32, and we are multiplying it with 1,000 because we are measuring in second. So the value comes to be 699 millimeter of mercury per second in this case, which indicates LV systolic dysfunction, because normal value is more than 1200 millimeter of mercury per second. A very modern technology is the global longitudinal strain with spectral tracking echocardiography, which is said to be very, very reproducible and feasible technique also. And it offers incremental prognostic data over LV ejection fraction. And the literatures have shown that it is an early marker of systolic dysfunction. This is done by using a software called spectral tracking echocardiography. So where we assess the motion of the myocardium, the segmental longitudinal strain is measured in apical 4 chamber, apical 2 chamber, and apical 3 chamber. And then the machine computes and takes the average value and gives it in bullseye plot. Normally, bullseye plot is bright red. Bright red indicates the myocardium is healthy and strain is normal. And the normal value of GLS is -18 to -22%. So a more negative value is good for the myocardium. If there is a change of color from red to pink or white, it indicates abnormal strain. Look at this patient, a patient of anteroseptal MI. Large area has been involved, and we do the spectral tracking echocardiography to get the global longitudinal strain, and we get a value of only minus 9.9%. And that indicates a larger infarction with severe systolic dysfunction. Here is another case of severe aortic stenosis. As you see, the LV is contracting very nicely, and we got an ejection fraction of 60%. And there is a mean gradient of 56 millimeter of mercury, so it's a severe aortic stenosis. But as we do the GLS, we see that GLS is only minus 5.9%. So this patient is having subclinical LV systolic dysfunction, though we got normal ejection fraction. So the patient should have the aortic valve replacement as soon as possible. Let us go to the LV diastolic dysfunction now. Let us start with a patient who is 60 years old, obese male, presented with progressive exertional dyspnea with fatigue. And on examination, we got all the findings of congestive heart failure. Now, what is the cause of this congestive heart failure? Obviously, we go for echocardiography to rule out the systolic dysfunction, and we see that there is no regional valve motion abnormality. LV is contracting very well with an ejection fraction of 70%. Then what is the cause? So we do the Doppler echo, and we see that patient is having diastolic dysfunction with elevated LV filling pressure. So this patient is basically in diastolic heart failure with preserved ejection fraction, which accounts for 40 to 50% of all heart failure. We have to know the diastolic, how to assess the diastolic function by echocardiography, looking at the structural problems as well as the functional problem, because we get elevated LV filling pressure in advanced stages of diastolic dysfunction, because that is the final common effect of diastolic dysfunction, which results in shortness of breath, and raised LV filling pressure is a marker of poor prognosis. And moreover, as per the latest recommendation of AEC, the classification or grading of diastolic dysfunction is based on the presence or absence of elevated LV filling pressure. So we need to know the LV filling pressure also. Now, if we look at the 2D echo parameters, we get the objective evidence of cardiac structural problem like asymmetrical septal hypertrophy, regional valve motion abnormality. In case of MI, all these findings point towards the diastolic dysfunction. We can assume that these patients will have the diastolic dysfunction. But out of all 2D echo parameters, it is the enlarged LA, left atrium, which is a robust indicator of diastolic dysfunction with elevated LV filling pressure in absence of anemia, atrial fibrillation, mitral valve disease, and athletes. Now the question is, how do we measure LA? We usually measure LA in external long axis, which is an antero-posterior diameter. Now, LA is a three-dimensional structure. It has the superior inferior diameter or medial to lateral other than the anteroposterior diameter. And it may so happen that anteroposterior diameter is normal, but the LA is increasing in lateral to medial direction or superior to inferior direction. So as per the latest AEC recommendation, anteroposterior linear dimension should not be used as the sole measure of LA size. So what do? We measure the LA maximum volume index by biplane area length method from the apical 4-chamber and apical 2-chamber view. We choose 1 to 2 frames before mitral valve opens. That time LA is in its maximum volume. And then we measure the area in 4-chamber, length in 4-chamber, area in 2-chamber, length in 2-chamber. Out of these 2 length, we take the shorter value, and the difference should not be more than 10%, and apply these values in this formula to get the LA volume, and divide it by body surface area to get the indexed LA volume. Upper limit of normal is 34 ml per square meter of body surface. Now let us go to the mitral inflow pattern for assessment of diastolic function. Now that we do from the apical four-chamber view, we put the sample volume at the level of the tip of mitral valve leaflets and get the pulse wave Doppler. So normally we get two waves. Normally the E wave is more than the A wave, as we call this E and A. So E is more than A normally. Now, as the relaxation abnormality sets in, E wave becomes smaller than the A wave. Now, as the diastolic dysfunction advances, LA pressure rises, the E wave becomes taller than the A wave. And over a period of time, further advancement of diastolic dysfunction takes place. LV becomes non-compliant, LA pressure greatly rises, resulting in very tall E and a small a, and this is called the restrictive pattern. So now if we look at this pattern, pseudonormal, which is where LA pressure is moderately increased, and look at this normal pattern, they look very similar. From here onward, the relaxation abnormality is there, but it is because of the raised LA pressure, this pattern is changed from the impaired relaxation to the pseudonormal and restrictive pattern. Now, how do we differentiate this pseudonormal from normal? We have two methods. One is the preload reduction method, which is called Valsalva maneuver, and also by utilizing the tissue Doppler velocity and measuring it in the mitral annulus, we can differentiate. Now let us see how Valsalva maneuver goes. So this is a normal person having a normal diastolic flow E more than the A. I ask the patient to do the Valsalva, and then I see that both E and A are reduced proportionately, keeping the ratio just like before. But look at this patient. This is a case of hypertrophic cardiomyopathy with obstruction in the mid cavity with enlarged LA, and I get a pattern where E is more than A. So to differentiate, I ask the patient to do the Valsalva. As he does, it reduces the preload, and look at the pattern now. It has gone back to the impaired relaxation pattern where E is less than the A wave. Or we can utilize the tissue Doppler velocity in normal patient where E is more than A. The tissue Doppler velocity both at the septal and the lateral annulus will show E prime more than A prime, as you can see. But in case of a pseudonormal pattern, you see it never lets us down. E prime will be less than the A prime, showing that this is a pseudonormal pattern. This is a pseudonormal pattern because tissue Doppler velocity is giving the correct picture of E prime less than the A prime, both at the septal and the lateral annulus. Now, taking the measurement of a ratio of E by E prime, we can predict the LV filling pressure. Look at this patient. That same patient, hypertrophic cardiomyopathy, we measure the E velocity and E prime velocity at the septal annulus, get a value of E by E prime, again measure at the lateral annulus, get a value of E by E prime at the lateral annulus, take the average, and it turns out to be 20.12. And as per the latest guidelines, average E by E prime more than or equal to 14 predicts the raised LV filling pressure. Now, let us see this algorithm given by the AEC for grading of the diastolic dysfunction in the patients with myocardial disease with reduced ejection fraction or normal ejection fraction. First, let us look at the left arm of this flow chart. So if the patient's E by A ratio is less than 0.8 plus E wave velocity less than 50 centimeter per second, straight away in this pattern, we can say that LV filling pressure is normal, so it is a grade 1 diastolic dysfunction. On the other hand, if we look at the left hand, the right arm of this flow chart, where E by A is more than 2, as in this case of amyloidosis, you can see a large LA, and I look at the LV. Here I get an E tall E and small a with the E ratio more than 2. And from this pattern, straight away we can say that it is a grade 3 diastolic dysfunction with raised LV filling pressure. Now, if it is in this middle arm where we get this type of patterns, E by A more than 0.8, as in this case, plus EUF velocity more than 50 centimeter per second, or EA ratio falls in between 0.8 to less than 2, then we cannot say about the LV filling pressure or the grading of diastolic dysfunction in these two patterns, looking at the EA velocity or the ratio, and we need additional parameters to comment on the LV filling pressure. So what are those parameters? It's the LA volume index more than 34 ml per square meter, which I have already explained. Average E by E prime more than 14, I have already explained. The third additional parameter is the raised pulmonary arterial pressure, systolic pressure from TRZ. So we look at the TRZ, and here we get a velocity of 3 meter per second. So normal value is less than 2.8. So it indicates there is raised raised pulmonary arterial systolic pressure. So it indicates elevated LV filling pressure. Now, out of these three criteria, if 2 or all 3 are negative, then we say it's a grade 1 diastolic dysfunction with normal filling pressure. If 2 or 3 are positive, it falls into the grade 2 diastolic dysfunction with raised LA pressure. But if we only have 2 criteria available, suppose there is no tricuspid valve regurgitation, and out of these 2, all 2 are negative, then it again falls into grade 1. And if 2 are positive, it goes to grade 2. But if only 1 positive and 1 negative, we cannot determine the LA pressure, and we cannot comment on the diastolic dysfunction grade. But we can always take the help of other parameters like pulmonary venous flow pattern, which is normally, normal flow. Pulmonary flow pattern shows systolic wave more than the diastolic wave. But in case of reduced ejection fraction, patients having myocardial disease with reduced ejection fraction, if the systolic wave is less than the diastolic wave, as in this case of anteroseptal MI, it indicates raised LV filling pressure. But this is not applicable in case of healthy young with normal ejection fraction, mind it. So ejection fraction should be reduced with myocardial heart disease. Or we can take the help of isovolumic relaxation time, which is normally less than 70 milliseconds. We measure it by keeping the pulse Doppler in between mitral valve and aortic valve, measure the time between the aortic valve closure and mitral valve opening. This time is prolonged in grade 1 diastolic dysfunction with normal filling pressure, but when it shortens, it indicates that LV filling pressure is high. So it has got a challenge, of course, of tachycardia. We can also use the mitral M mode propagation velocity by doing M mode at the mitral inflow and measuring the slope from the mitral valve level till 4 centimeter depth. And if the value is more than 50 centimeter per second, it is normal. In diastolic dysfunction, it is less than 50. And E by VP more than 1.4 predicts the raised LV filling pressure in patients with atrial fibrillation. But we should remember it has got a lower feasibility and reproducibility. Now let us look at this group of patients.
1 minute left.
Okay, so I'll finish. In spite of grade 1 diastolic dysfunction, they become symptomatic, especially when they do exercise. So in these cases, we consider about diastolic stress test to find out whether they are in early failure and on HIP-PIF. This because there is no augmentation of myocardial relaxation in this group. So E wave rises, but no change in the E prime, increasing the E by E prime ratio. So we take the parameters at rest and after walking on the treadmill, and look at this patient at rest. E wave was 72, increased to 106 centimeter with stress, whereas E prime has reduced to 6 from 7. So post exercise E by E prime more than 13 has 90% specificity and 60% sensitivity for raised LV filling pressure. We can do passive leg raising test also. Here we have the advantage of heart failure. There is no tachycardia. Now, we have seen that enlarged LA is a marker of chronicity. What about the early phase of diastolic dysfunction? We cannot consider LA volume for the early phase of diastolic dysfunction. All these lead to advanced techniques where LA strain has gained very importance. A lot of papers are getting published. Abnormal LA strain indicates presence of HIP-PIF, but this requires standardization. It is not yet a routine practice. So to conclude, I'd say that assessment of LV function is one of the most critical part of echocardiographic examination, but it should be done carefully, making it very simple and following the algorithm. Thank you.